Well, so what else is new with the guidelines? And I found this challenging mostly because how do you discuss the guidelines without having slide after slide of text? It's hard to put nice figures and charts and those kind of things when you're reviewing the guidelines. So there are a lot of those slides. Hopefully I've kept those to a minimum. For those who have not been there, this is Zion National Park and the top of a hike called Angel's Landing, in which there is a guideline to help you get up there. There have been people who've fallen off this hike and have died. So here are my disclosures, and this taken from Pirates of the Caribbean. The code is more like guidelines rather than actual rules. So just remember, rules are to be followed and they're associated with negative consequences for noncompliance. Guidelines are recommended best practices to help you get to the point, to the target where we're trying to teach patients, to have patients reach. But there's always reasons, every patient is different, not to be specifically following the guidelines, and there are a lot of them. And so we got published just last month the ACG guidelines for UC in adults. The AGA published also in 2009 the mild to moderate UC. The management of the moderate to severe is in development. It just got released for comments. So that will be coming out shortly. Management of Crohn's in 2018, therapeutic drug monitoring, somebody else is talking about. I'll touch on the management of Crohn's after surgical resection, some preventive care. Somebody else is talking about vaccines, so we'll exclude that. But then there's all these other societies and groups and countries that have their own guidelines, and there's many more. And I'm not on the groups that help make these guidelines, but I do think there would be an advantage from the ACG, the AGA, CCFA, even ECHO, getting together and trying to come up with one standard set of guidelines. So here's the ones that we will touch on moving forward. And the new guidelines outline treatment approaches based on disease location, disease severity, and prognostic factors that were touched on by Gil. Separate induction versus maintenance, and there's also a focus on the goals of the patient and the provider. So we got to take their consideration to what their concerns are about different therapies, be it biologic versus non-biologic. And so those are also touched on. It incorporates newer therapies that have come out since the guidelines, and after hearing Sid and Mike's talk, the guidelines are already out of date, or will be. So there's clinical situations such as prior anti-TNF failure that were not dealt with the prior guidelines in colon cancer prevention. So not everybody fits neatly into guidelines. There are some situations that are discussed in text or put out as summary statements rather than grade methodology statements, because the data is lacking to fully assess those by the grade guidelines. So for ulcerative colitis, this is out of the ACG guidelines that came out in March. They've proposed this new activity index. It's fairly similar. They have included urgency. And if you think about patients you see, there are patients who have different symptoms in different categories of these. But it's a general assessment as to how severe a patient's disease is at the time that you're seeing them. They do recommend testing, stool testing to rule out C. diff. For patients who have severe disease or in a hospital, they recommend DVT prophylaxis. And they suggest treating to mucosal healing, defined as a Mayo endoscopic score of 0 or 1, because this will increase the likelihood of a sustained steroid-free remission and prevent hospitalizations and future surgeries. So for induction of remission for patients with mild to moderate UC, the choices vary depending on what the extent of disease is. The recommendations for proctitis is for rectal suppository of a dose of at least 1 gram a day. For the patient who would value the convenience of oral therapy over the improved efficacy of rectal therapy, oral therapy is okay. And you also need to then take this into consideration, on how you're going to approach these things. So the patient who's having 4 or 5 urgent bowel movements a day and works in an office has a different set of priorities than the patient who has the same symptoms as his elementary school teacher or a truck driver or a surgeon. I mean, you can't unscrub every time you need to go into the OR to have a bowel movement. So you may vary from the guidelines depending on what your patient's situation is. So for left-side disease, rectal enemas at a dose at least 1 gram a day preferred over rectal steroids. It was suggested, meaning the data wasn't quite as strong, that the rectal 5-ASA enemas at a dose 1 gram a day combined with oral medication of at least 2 grams a day. AGA said 2 to 3 grams a day compared to oral agents alone. And then for extensive disease, you need oral therapies. Suppositories or rectal therapy may be of more benefit to urgency, but you need to get the whole colon treated. So they recommend oral therapy of at least 2, AGA 2 to 3 grams a day. Once a day dosing is recommended for induction and maintenance of remission. So too many times patients come on 2, 3, 4 times a day. Mesalamines, they can take them all at once a day. It improves compliance. Just get the dose in that day. So those intolerant to 5-ASA, they recommended oral budesonide, the MMX, for colon delivery. I'm sure you all have seen this too. Some pharmacists look at budesonide, they try to substitute in the generic ileal release formulation. It's not the same. You got to tell the patients the 9 milligram tablet that they need. And they recommend the MMX over the oral systemic steroids for induction and remission. So for maintenance of remission then, once you have them in remission, they still recommend continuing with the mesalamine. I'll be honest with you, most patients don't want to do suppositories long term, so I try to get them onto oral therapy. For left-sided or extensive disease, they do recommend oral therapy of at least 2 grams a day for maintenance of remission. They do recommend against systemic corticosteroids for maintenance of remission. This is a strong recommendation. They're not effective, and steroids aren't good for you. This is not new, but I figured we're reviewing the guidelines, so we should include that. So for moderate to severe UC, they recommend the oral MMX budesonide, and for the moderate to severely active UC, oral systemic steroids, anti-TNF therapy with a combination of a thiopurine or vedolizumab or tofacitinib. And for the patients who have previously failed anti-TNF therapy, then they recommend vedolizumab or tofacitinib. They did not make recommendations for an anti-TNF versus veto versus TNF because the head-to-head trials were not available or haven't been completed yet. Comment on the trial that was mentioned, head-to-head comparison with Humira and the vedolizumab. Clinical remission, vedolizumab did better, but steroid-free clinical remission, which I think is the more important endpoint, there was no difference. So we need to wait for that full paper to come out to see the details of that study. So for the moderate to severe patient who you now have in remission, you need to maintain remission. Again, steroids are not recommended. If you went into remission on steroids, then they suggest thiopurines for maintenance of remission compared to no treatment or steroids. I'm not sure anybody else would do that, so didn't find that recommendation all that helpful. I think thiopurines have been shown to maintain remission, so that's a good statement there. If you went into remission on TNF, then continue the TNF. If you went into remission on vedolizumab, then continue the vedolizumab. Same thing with tofacitinib. Like how Mike put it, dance with the one that brung you. So if you got in remission with that agent, you can continue it other than steroids. What about the hospital patient with acute severe UC? Again, you want to exclude C. diff. If they've been on outpatient steroids, you need to exclude CMV. Recommend a total of 60 milligrams of methylprednisolone. ACG also recommend hydrocortisone 100 milligrams 3 or 4 times daily as an option. Doses higher than that are not effective and just lead to increased complication. So if you fail to respond to intravenous steroids by 3 to 5 days, then you need rescue therapy, either with infliximab or cyclosporin based on provider experience with the agent. If they had previously failed an anti-TNF agent, low serum albumin, as you heard, biologics get cleared faster, the response rates are less, and then a surgical consultation should be obtained at that point because you don't know who's going to respond to these therapies. This is a quote here from the ACG, but the AGA guideline had a similar statement that although accelerated high-dose induction regimens may be appropriate for a subgroup of patients with severe UC, and they're talking about infliximab, that their routine use cannot be recommended with the existing evidence. So what they're talking about is the severe UC patients. There's accelerated dosing going with 10 milligrams per kilogram, following the CRP, redosing early if they're not responding. So for maintenance remission, if it's achieved with infliximab, then continue with the same agent. If you achieve remission with cyclosporin, then it's suggested to maintain remission with either thiopurine or vedolizumab. Colorectal cancer prevention, this is not new. It's the standard. You need to start surveying these patients with disease beyond the rectum 8 years after diagnosis and every 1 to 3 years based on disease activity over that time, histological, the findings of the histology on the biopsies. For patients with IBD and PSC, it is annual surveillance colonoscopy at diagnosis. The ACG did not sign on to the scenic guidelines regarding chromoendoscopy, but they're now more in line. So standard definition colonoscopes, I don't think anybody's using anymore. They do recommend using dye spray chromoendoscopy with either methylene blue or indigo carmine. If you're using HD scopes and processors and monitors, you got to have the whole system in order to be a high definition system. Then they recommend, they suggest either narrowband imaging or chromoendoscopy to increase the yield of detection of dysplasia. So based on our current evidence, it's unclear whether segmental random biopsies are still required during surveillance colonoscopy in UC. And when dysplasia is found and is not resectable or is multifocal, then colectomy would be the pathway for those patients. If you find an area that's dysplastic and you can resect it out endoscopically and there's no dysplasia elsewhere, then those patients can go on to subsequent surveillance colonoscopy. So what about Crohn's disease? Assessment is based on symptoms and endoscopic evaluation. The SCSCD scoring system is on Provation, which is the endoscopy note-generating system we use. I don't know if it's available on the other ones, but this is a way of quantifying how much inflammation and ulceration and areas that are involved in the colonoscopy. There's no role for serologic markers in the diagnosis of Crohn's, and ileal colonoscopy is recommended for diagnosis. However, about 20% of patients may also require an EGD, cross-sectional imaging, or capsule endoscopy to make the diagnosis. So bottom line, IBD patient, you do a colonoscopy, look in the TI. So what features are associated with a high risk of progressive disease? We heard Gil talk about this at the beginning. Young age, extensive bowel involvement, ileal colonic disease, perianal or severe rectal disease, those who present with a abscess or stenosis, cigarette smoking, and then visceral adiposity may be a marker for increased risk for penetrating disease. So for mild to moderate Crohn's who are low risk, have that or don't have a lot of those risk factors, treatment options include sulfasalazine for mild colonic disease only. I mean, you've got ileal colonic disease, small bowel disease. We're not talking about the sulfasalazine. Controlled ileal release budesonide, 9 milligrams a day, should be used for induction of remission in patients with moderate to severe Ulcerative Crohn's. However, for patients with low risk of progression, dietary manipulation, and we're trying to figure out what diet might be the best, is an option, but they require careful follow-up, not only for their symptoms, but is there worsening inflammation or disease progression? So that is acceptable, but a low level of quality of evidence. There is a trial going on now, sponsored by the Crohn's and Colitis Foundation, comparing the specific carbohydrate-free diet with a healthy Mediterranean diet to look at the effect of this diet on symptoms and on inflammation. Oral mesalamine should not be used, and that's a strong recommendation for Crohn's disease. So for the moderate to severe high-risk patients, oral steroids are effective. Thiopurines or methotrexate are effective for steroid sparing and maintenance of remission, but should not be used for induction. Anti-TNF agents are an option. Natalizumab is an option. Must be JC virus antibody negative, and you need to recheck this every 6 months if you're going to use this. Most people now are using vedolizumab rather than natalizumab, but I still have a patient or two who have been doing well on natalizumab, and we've continued that. Vedolizumab, ustekinumab are also options. Combination therapy of infliximab with thiopurines is more effective than treatment with immunomodulators or a biologic agent alone. This is the data from Sonic. So for patients who are naive to those agents, that is also a recommendation. So for severe and fulminant disease, these are the patients you have in the hospital. Intravenous steroids, same doses as we use for ulcerative colitis. Anti-TNF agents, all three can be considered to treat the severely active Crohn's disease patient. For the fulminant disease, then they recommend infliximab because that's the data that we have. Natalizumab, vedolizumab, and ustekinumab have not been studied formally in the fulminant disease category patients, so they were unable to make recommendations for those. So postoperative Crohn's, Crohn's disease comes back. Studies going back to the early 90s, the Paul Ruckert study, 75% of patients will have recurrent disease within a year. Other than follow-up and said, well, let's look at 6 months, the data was about the same. So prophylactic treatment is recommended after small intestinal resection for patients with risk factors for recurrence. Here from the AGA, those patients who are high risk or younger, if you've had penetrating disease or perianal disease, more than 2 surgeries, you're at increased risk for doing worse. Cigarette smokers also are at increased risk for recurrent disease, nearly double the non-smoker population. So selection of treatment should take into account these risk factors, and mesalamine is not recommended for low-risk patients. Metronidazole, doses of 1 to 2 grams a day can be used. For the high-risk patients, anti-TNF or thiopurines should be started within 4 weeks of surgery. Then post-endoscopic monitoring of 6 to 12 months is recommended in order to, regardless of therapy, to be sure their disease is staying in remission. If low-risk patients are having evidence of more aggressive disease, then you need to adjust your therapy following the treat to target. So growing evidence demonstrates the anti-TNF agents, though, are most effective. In your slides that you have access to, there's more than what I'm going to present, but this is the PREVENT study. The clinical endpoint of symptoms did not correlate, but we knew that that was likely to be the case. But if you look at the patients these were randomized to either placebo or infliximab, Ruckert score is 0, meaning there's no ulcerations, no inflammation, 83% of the patients who were on infliximab versus only 28% of the patients who were on placebo. If you look at the more severe ulcerations, these are the patients who are going to become symptomatic, who are going to develop another stricture or perforation. So it's I3 or 4 disease. It was only 17% of the patients on infliximab compared to 72% of the patients who were on placebo. Preventative care. We need to assess and manage patients' stress, depression, anxiety, whether you do it yourself or you refer them to a psychologist or psychiatrist to help manage this. This is important. Depression, stress, anxiety leads to decreased quality of life. There's lower adherence to provider recommendations, and this needs to be addressed. So women with IBD who are on immunosuppressives, so not women not on immunosuppressives, should undergo annual cervical cancer screening. Some recent recommendations that are not included in the IBD guidelines or the CDC yet say that if your pap smear is negative and your HPV negative 3 years in a row, you can go out to every 3 years, but not to the every 5 years that's recommended for the general population. Trying to get more details in this about the recommendation about whether it varied based on if you're HPV or positive or not. I really couldn't find that, but I was actually learned something and surprised that 80% of women are exposed to HPV somewhere during their life. And if you're on immunosuppressive drugs, it's more likely then to become chronic, meaning you can't clear it. So that's why that is pushed. Who should get screened for osteoporosis is more difficult. We certainly know that high long-term steroid use is a risk factor. Vitamin deficiencies, calcium, severe malnutrition, age over 65 are all risk factors, but IBD patients are largely young, and who should get bone density screening is difficult to, I think, put a precise number on or precise recommendations. So they had a conditional recommendation they should be screened with low quality of evidence. Haven't studied it, just personal pearl I'm going to throw out to you. Ask them if their grandma's regulation grandma height and kind of humped over. If they got a family history of IBD, I found that to be a very strong predictor of patients who have are likely to have abnormal bone density. So patients with IBD also should be screened for melanoma, and this is independent of use of biologic therapy. So this study here, which this is based on, there was the relative risk of 1.37, so a 37% increase in the risk of melanoma compared to the general population. Immunomodulators, 6-MPA azathioprine is also a risk factor for non-melanoma skin cancer, especially over the age of 50. And then patients with Crohn's should be counseled to quit smoking. And this is a strong recommendation, but this is out of Belgium. And they just asked their patients, so active smokers, former smokers, non-smokers, increased risk of Crohn's disease, need for surgery, recurrence after surgery. Their answers were certainly not, I don't think so, I don't know, I think so, and certainly. And there's not a very high number up here of smokers, at least who admit that they know that this makes their Crohn's disease worse. I tell them all. I'm curious if I ask my patients if they're actually listening or they're putting that aside. So went over by a few minutes. Thank you, and I guess we'll do questions at the session. So thank you.